Hello. Welcome to the CME certified activity titled Autologous Hematopoietic Stem Cell Transplantation and Mobilization in Myeloma, Current Debate and Developments. I am Parameshwaran Hari, Professor of Hematology at the Medical College of Wisconsin. And joining me today is Dr. Neena Shah, Associate Professor of Medicine at the University of California, San Francisco. We have a two-part presentation. In part one today, we'll be discussing the most recent clinical data on autologous hematopoietic stem cell transplantation and mobilization in multiple myeloma, and provide evidence-based updates and some expert insights on this topic. Here are our disclaimers and disclosures. So to start off with, let's talk about the treatment framework for people with newly diagnosed myeloma.
Right.
So we typically divide these patients into transplant eligible and ineligible. Would you agree with this framework?
Yeah, I think this is one of the things that we've come to as a decision point when we first meet a patient is who is transplant eligible and who is transplant ineligible. And that's something we're going to talk about a little bit later, but it's a big decision point because it changes sort of how we approach each patient, right? Right,
exactly. But on the other hand, there is some, nowadays with modern induction therapy, there are a bunch of people who we would have thought transplant ineligible at the beginning, right, whose main problem was multiple myeloma,
right,
and with induction treatment they get better,
right,
and then they become eligible. And as we have moved away from melphalan in the initial induction regimens, almost anyone can be stem cell mobilized these days, and it's very important to keep the eligibility question in mind when you see a person up front, but we also need to consider that people could go back and forth between these eligibility versus ineligibility buckets.
Yeah, I think that's a really important point you make because the person that you see at the beginning may not be the same patient that you see 2 cycles into their therapy. So exactly, what we have here on the slide with people being transplant eligible or ineligible may change and be a dynamic course after they have some cycles of therapy.
I think for the people watching the CME, I would say the arrows going back and forth between the transplant candidacy question is very important to focus on because you don't want to commit somebody against something very effective such as transplant by putting them up using their eligibility question just at the beginning of their disease. So one of the questions that's always been asked in myeloma ever since transplant became, so to speak, standard of care is it still needed?
Right.
As chemotherapy pre-transplant gets better and better, we get
more and more
people, more and more people go into complete remissions, and then the question always comes up, do those people need a transplant? Who needs a transplant? Can we defer transplant? So I think these are some of the things that we should answer today.
Absolutely.
Upfront versus later, is there a role for transplant still in the era of modern, very effective induction regimens?
Right.
So here's a couple of studies that we have for our viewers, and these are the 2 big studies that we should focus on, I think.
So on the top of this slide, you can see how there is an ongoing study. This study has been performed in Europe and is also now being performed in America, but the results from the European study have been available to us sooner, and so we've been able to look at that. So this study allows patients who are transplant eligible to receive bortezomib, lenalidomide, and dexamethasone, which is our standard induction regimen, and we'll get to that later. And they get it, but they're upfront randomized. So half of the people will be getting just the bortezomib, lenalidomide, and dexamethasone for 8 cycles without going to transplant right away. The other half of the people will get the bortezomib, lenalidomide, and dexamethasone for 3 cycles, and then undergo stem cell collection and then transplant, thereafter getting 2 more cycles of what we call consolidative bortezomib, lenalidomide, dexamethasone. And I just want to point out that in both groups, the patients are allowed to collect stem cells, and this is something very important that we should talk about. And so the comparison is between these groups who get an early transplant, that is after their 3 cycles, versus those who wait until relapse to get a transplant. And all of the patients have gone on to get lenalidomide maintenance, which we consider standard of care. And so this is very interesting because it's one of the first trials in the novel era, one of the major trials that's been able to help us answer this question.
This is another major study that actually asks 2 or 3 different questions. A large European study known as the EMN02, European Myeloma Network 02 study. Here again, the induction is specified as what we call CyBORD, which is
Right.
cyclophosphamide, potassium, dexamethasone. Then there is a randomization to transplant. And again, within the transplant subgroup, there is another randomization to single transplant versus double transplant.
Right.
And the people who are not randomized to transplant end up on a combination of bortezomib, melphalan, prednisone. And turns out that cumulatively you get almost the same amount of melphalan in that cycle.
As you would.
As you would with a full dose during
Transplant.
transplant. And then patients get re-randomized to consolidation,
Right.
which is bortezomib, lenalidomide, dexamethasone consolidation versus no consolidation. And then lenalidomide maintenance is uniform for everyone. I think some of the important thing about these two studies is that they both involve bortezomib, a proteasome inhibitor.
Right.
They both involve lenalidomide. In the EMN study, the lenalidomide comes in a bit later, at
Right.
maintenance only.
Right.
So we actually have data from previous studies that bortezomib or a proteasome inhibitor is an important part of the induction therapy.
Right, which I totally agree with.
Absolutely. And then the second thing is that lenalidomide maintenance is no longer a question
Right.
because both of these studies mandate lenalidomide maintenance
Right.
in everyone. So here are the results from the EMN study, which were actually presented at the ASH meeting recently. And here again, you can see that the progression-free survival for the auto transplant population was not reached whereas it was 42.5 months for the VMP or
Right.
the non-transplant,
The non-transplant.
or the late transplant
Right.
population. The three-year progression-free rate was also pretty significant, which means that about 2/3 of the patients were progression-free at 3 years in the
Right.
transplant arm. Now the difference becomes even more drastic for people who were high risk by cytogenetics.
Right.
And that's a pretty impressive result, wouldn't you say?
Yes, I think this is one of the most difficult populations that we treat in the high risk, and we'll get into that a little bit later also. But it's good to know that when you have a high risk patient or if you have high risk myeloma, that going for a transplant in some ways early may be beneficial. The reasons for that are not clear. We don't know the biology of why that's clear.
Right.
But this study seems to indicate that for those patients, it is a good idea to consider transplant early.
Right. So for the high-risk patients in this study, which is about 133 people who received transplant, the median progression-free survival was 42 months, which is very similar to the standard risk
Yes.
patients who didn't get a transplant.
Right.
So it again brings to the point that high-risk people do benefit from transplant,
Right.
but not as much as the standard risk patients.
Right.
So it's not a good reason to deny transplant to high-risk patients,
Right.
which was one of the prevailing thoughts, probably about 5 to 6 years ago. I think we should get away from that. High-risk people do get benefit from
Intense chemotherapy.
intense chemotherapy, and perhaps they are the patients who need to get to what we call a minimal residual disease
Right.
negative remissions, and transplant remains an important tool to get
Yes.
there.
I was going to say the same thing, that one of the reasons we think the benefit exists is because you get a deeper response. You get more of the disease eradicated from the body, and we know that depth of response is related to length of remission or time before people will progress again. And even more now, and we'll talk about this later, with minimal residual disease monitoring, you can sometimes overcome the bad risk of the cytogenetics by getting to that
Exactly.
MRD negativity. So if transplant can help with that, this will be good for our patients.
Absolutely. So here is a summary slide of all the new drug versus auto transplant
Right.
studies in the modern era. I would point out that the first two are studies that did not involve proteasome inhibitor
Right.
or bortezomib.
Older studies.
Older studies.
Yeah.
And those are the two studies that show an overall survival advantage for transplant.
Right.
And the criticism against that is that they didn't have bortezomib
Right.
in the induction regimen, or in fact nowhere in the
right.
regimen at all. And the bottom two are the ones that we just discussed.
So that's one of the reasons why I think these discussions in the clinic are so important, because you never want to say you have to do this or you have to do that. We can present data, but we should also remember that so far all of the data is in favor of early transplant.
Absolutely. And again, I'm always humbled by this slide,
Yeah.
which shows us the advantage of that maintenance gives to patients.
Right.
Who, when I started my career, I still remember the early half of my career. We used to say that majority of patients after a single autologous transplant relapsed in the second or third year. Between the second and the third years, that's for 50% of patients
Right.
who relapsed. Now, in the era of maintenance, these are data that were submitted to the FDA, for which has now approved lenalidomide
Right.
maintenance in the United States. And you see that study one, which is the US CALGB 100-104
Right.
study, the median overall survival in patients who took a single transplant and lenalidomide maintenance was in their 10th year, 9.3 years,
Yes.
which means that 50% of the patients in the 2004-2005 era who went on to a single transplant followed by lenalidomide maintenance were alive 10 years later, which is amazing.
It's amazing, especially considering what used to be.
So here we go at the IFM DFCI study, which is talked a little bit about. That's the IFM 2009 part, is the part that's already been reported
Right,
by
the European part.
By Dr. Tal
Right.
from France in New England Journal of Medicine this year, whereas the DFCI part, which is the Dana-Farber part, also done by the BMT-CTN, Bone Marrow Trials Clinical Trials Network, as the determination trial, which is still ongoing and almost accrued at this point. This study, again, as you said, Nina, randomizes patients after a collection to ongoing bortezomib, lenalidomide, dexamethasone, which then amounts to 8 cycles for people who don't get a transplant. And for people who get a transplant, it turns out to be 3 cycles in induction, a single stem cell transplant with high-dose melphalan, followed by consolidation with bortezomib, lenalidomide, dexamethasone for 2 more cycles, and then lenalidomide maintenance for a year, as reported by the French.
Right, although longer for the Americans.
And indefinite maintenance for the Americans.
Right.
So here are the final data from the New England Journal paper by Dr. Tal. As you can see, the transplant arm, as expected, had a higher complete remission rate, higher percentage of people getting to very good partial responses or more, and more importantly, as you said, the MRD negativity by flow cytometry.
Right. I think this is really important because it really brings the question of early versus late transplant into the modern era. As you mentioned already, that it's triple drug regimen, which is pertinent to our practices now, and bortezomib-containing regimen. And this is something that people can take back to their clinics and say, okay, I do this in my clinic, or I got this from my doctor, and I have data to show that there's some benefit for my getting a transplant earlier. Right. And again, it's a decision that everybody has to make together, but it helps patients to sort of have more clarity in this respect. Also, as you mentioned, that there are deeper responses in the transplant group. And like we've talked about, it seems that deeper responses correlate with better outcomes long term.
Exactly. So this study was important in that it didn't show up overall survival difference for the transplant versus non-transplant arm, but functionally these arms turned out to be early transplant versus late transplant, because the patients who were randomized to no transplant, 80% of them ended up getting a transplant in their first progression. Right. So the progression-free survival was significantly better for transplantation, but the overall survival was not. But at progression, remember, the non-transplant arm really ended up being a late transplant arm. So I think it tells us the following points. One, the importance of a transplant in giving you a long first progression-free interval. And again, going back to the natural history of myeloma, it turns out that for the majority of patients with myeloma, the first progression-free interval is probably going to be their longest progression-free interval, because we know that the disease morphs, clonally evolves, and badness comes a little bit further up front.
During relapses.
During relapses. It becomes more difficult of a disease to control at relapse. So I think the first progression-free interval cannot be, it has to remain an important consideration when we choose treatments.
We have to optimize that.
We have to optimize that, and increasing that would be, the way to get to a cure.
And things happen, as you mentioned, and 20% of people may not be able to get that transplant later. So it's something to consider. Also, I think it really drives home the point that stem cell collection is very important, and whether you're going to use it now or later, it's something to consider after a few cycles of therapy.
Exactly. So 80% could get to a transplant at relapse, provided they had stem cells in storage. If you didn't get a transplant referral, or if you didn't get a collection done at the early time point, that 80% is not going to happen. It'll be much lower. So that's why
you have to think in advance about that.
It is an effective option, and if you didn't, for whatever reason, if you didn't have it up front, it's important to keep that option open for later. So which brings us to this point, which is, when should you refer to a transplant center?
I always encourage referring providers, and even in our own practice with newly diagnosed myeloma, to start the transplant referral right away. Number one, people, as you mentioned, may be considered ineligible initially, but after having a couple of cycles of therapy, they feel better, they're more functional, they're getting back to who they were, and they now become eligible. So you don't want to close the door right away. It takes time to plan for a transplant, so I like to see them up front. What about you?
That's exactly my view too. I think every patient with myeloma who is, if they're eligible or borderline eligible for a transplant, they should come and have a discussion about it.
Exactly.
Transplants have become substantially safer in the last decade or so.
Yeah, we can do them as an outpatient now.
Actually, a vast number of patients are actually getting these transplants an outpatient.
Yeah.
And secondly, as we just said, if you don't get it collected at the beginning, you're very unlikely to make it happen.
Right.
And outside of a well-designed clinical trial, I think the standard of care should still involve an upfront transplantation for anybody who's eligible. And if you're on a clinical trial, it's again important to collect the stem cells and hold, because there is no study that shows that transplant is disadvantageous in myeloma. No, such a study doesn't exist.
Right. So that's never been shown.
Right.
If anything, there may have been non-inferiority or equality, but it's not that, or equivalence, but it's not that it's ever been shown to be inferior, even though it's an intense therapy. And I think just this issue of when to collect stem cells, I would think maybe after somewhere between 4 to 6 cycles in that range of induction therapy. What do you think?
Well, I agree, and I know it has gone between 3 to 6 cycles.
Whatever
in
you
that
can
range, yes.
organize.
And it's important to, we will get to mobilization in a second, but even with very effective mobilizing drugs, some people become ineligible for mobilization or unable to mobilize stem cells because of repeated cycles of therapy.
Right, so you want to get them early.
You get them early. So again, what are the barriers to this happening? There are some sobering data that has come out from CIB MTR type comparisons, which talk about the barriers to transplant, and we have analyzed some of the social, financial, and other barriers. And then, even if you get referred to a transplant center, there's a barrier to transplant in terms of mobilization issues. So we'll discuss those in a second. So here are the US transplant utilization rates. This is a paper that just came out in the journal Cancer. So this basically gives you a percentage of patients who with myeloma who get to a transplant. And it's only for patients below the age of 65, so that there wouldn't be much questions about eligibility. So here you see that only about 30% of the patients who are eligible for transplant end up getting a transplant in the United States, even in 2030.
Which I found surprising.
Yes.
Because I would think that more would be getting a transplant based on the data that exists, but we often don't see the people who don't get referred, right?
Exactly. And the disparity is even wider for patients who are of ethnic minority, like blacks or Hispanics. So that in those populations, it drops down to 20% or lower than 20%. And it's important to study the barriers to transplant, because our treatments are only as effective as the people who get them.
Delivering.
So you could have 1,000 patients treated on a clinical trial, which shows 10-year survival. Whereas if it doesn't translate to the 25,000 patients living with myeloma, it's not effective. We can only, it's important to study these barriers. And again, it's this slide actually talks about some of the barriers that you just mentioned. Economic barriers, social support barriers, referral bias. And again, healthcare system in-network, the decisions, sometimes healthcare systems become very restrictive and they don't want to refer out to another system that is not within their network. And I think it's very disadvantageous to patients if they don't get the expertise sometimes which exists in their own town because of narrow network practices by health systems who are only focusing on profit at that point. Here's again some data suggesting that the probability of getting a stem cell transplant for myeloma is significantly lower, or there's much higher odds if you are a white individual versus a black individual.
And male.
And male. So, we see that age, ethnicity, and female sex are the 3 biggest barriers that exist, and for no good reason.
For no good reason. There are no differences in outcome.
Absolutely.
And this tells us that we should be more mindful that maybe we're not giving these opportunities to our own biases are coming in, and we're not offering these opportunities to these populations because we, as physicians, may not think that they're appropriate, but they are, and we shouldn't limit them based on any demographic information.
And again, age being a barrier, here is data showing that it's a very small proportion of patients who are above the age of 65 who get a transplant, even this is in the United States. Even if you look at the people getting it within the 12 months of diagnosis as upfront transplant or at some point during the course of their disease, still very, very low numbers. And remember, the majority of patients with myeloma are above the age of 65.
And people are willing to consider this as an option. So when I saw this data that so few patients above 65 are being referred for transplant, I thought we can make a difference here,
Absolutely. And as we said before, here is data suggesting that ethnicity does not affect outcomes. It's the same whether you're Hispanic or which we didn't think there should be any reason biologically.
But we had to prove it.
We had to prove it. And again, similarly, we have data suggesting that the older versus younger, progression-free survival from transplant is exactly the same, whether you're 18 or whether you're 70. So it suggests that the benefit in terms of controlling myeloma is not restricted based on age. Similarly, with renal impairment, even if you have severe renal impairment with on hemodialysis, transplant physicians have perfected the art of giving melphalan even in people on dialysis.
Yes, we routinely do this.
Exactly, and that should not be an indication, contraindication to referral for transplant. So here again is the unlikely but true is that we have this effective therapy, which is transplant followed by maintenance, but we're not utilizing it as we should. And this is a huge challenge for our patients. And I think we as physicians...
And for us, we have to make sure the word gets out and refer patients and not let our own biases get in the way when it's very possible to get this done for way more patients than we're doing.
And again, as in some ways, we have a new effective drug that comes out. There's always a hype about it, but it still turns out that every time it's transplant is compared with non-transplant, the benefits seem to be additive rather than bringing everything to the same level. So the newer drugs plus transplants now with maintenance are giving 50% of patients are alive at 9.3 years.
Yes, I mean this was unimaginable 15 years ago.
Exactly. So we have one of these old technologies which is still in vogue. At some point it may go away, but not right now.
And in the next session we'll talk about how we can even utilize that for more novel therapies to be on top of it.
Exactly. So then, one of the other things that we should mention in this context is mobilization. Because when you get to a transplant center sometimes, especially if you come late after multiple cycles of induction treatment, there is a challenge in getting enough stem cells taken from those patients.
Or known as mobilization.
Mobilization. So the mobilization, here is a curve describing how many cells are needed for a transplant.
And so we've generally thought, and we'll see this on the next slide, that you need at least 2 million stem cells or CD34 positive cells, which we call stem cells per kilogram. And you can get away with just that much. But as you can see, there are some outcomes that are slightly improved with higher stem cell quantities. Really, you don't need much more than 4 to 5. And as you can see, the minimum requirement is 2. We ideally target, I usually try to collect 5, 6, because we want to collect for 2 transplants, and that's something we're going to talk about in the next session also.
So these are recommendations from the International Myeloma Working Group, and similar recommendations have come from the ASBMT, American Society of Blood and Marrow Transplantation, that the minimum is 2, ideal targets somewhere in that 5 range, just as you said. And for myeloma, though, we should offer patients the chance of having some stem cells in the bank and not use them all up at the beginning.
I always collect for 2. Do you?
Absolutely. Absolutely. I think most academic centers that I know about, at least for 2 transplant. Sometimes if you get more, you can aliquot them into several bags. So that and it turns out that if a patient has a significantly prolonged first remission from transplant, they are the people who are most likely to benefit from a second transplant at relapse, as we will discuss in the... So here is the more cells better question. So again,
to a point.
To a point, they are. That's actually I think that's to get more cells, you have to put the patient through more and more sessions of mobilization or apheresis, and that would be the downside to getting it. But it'd be better to get as many cells as possible in the first 1 or 2 days of mobilization. And here are some of the mobilizing strategies, which.
So I think there's sort of 3 major tools we have to mobilize, or what I call take stem cells out of the bone marrow and get them into the blood. This makes it possible for patients to get their stem cells collected from a blood catheter instead of having to dig into the bone marrow, which was sort of the earliest way to do it. So the 3 tools we have are growth factors, so granulocyte colony stimulating factor, or what we call GCSF. And high doses of this not only increase your white blood cell count, but they sort of tell your stem cells to get out of your bone marrow and go to the blood. So that's one way. And with that alone, many times, actually often, we can mobilize patients and get enough stem cells. Some patients need a little bit more help, and for this we can sometimes use chemotherapy.
Right.
And ironically enough, giving chemotherapy, which we would think drops your counts, actually allows for a more robust recovery with this growth factor, this GCSF growth factor. And so that helps us when we think people might be a little bit difficult to collect. And finally, most recently, we've been being able to use a drug called plerixafor, which allows the cells that are stem cells to sort of unvelcro from the walls of the bone space and come out and be mobilized even better. And with that, we've had a really nice ability to collect people who we didn't ever think we'd be able to collect. And that's sort of now made this less of a barrier. I've really not had too many problems collecting.
I would completely agree with that. You know, it's almost very rare. That,
it's rare, right?
That you have a patient who's truly
you remember them. You know, it's so rare. Yeah.
And there are pros and cons for each strategy. The simplest one, I would say, is just growth factors.
Yes.
And because there are generic growth factors, so the cost factor is
also
significant. But again, you know, that's probably like the middle path.
Right.
And if you want to have more cells, obviously you would try to do either plerixafor, or use chemotherapy plus growth factors.
Right.
And there is some thought that there is a anti-tumor effect of chemotherapy when you do chemotherapy plus growth factors.
Especially with cyclophosphamide.
Especially with cyclophosphamide. But actually, the data are not truly supportive of that. And I know some physicians who always try to use that, because some of the earliest studies for transplant were done with cyclophosphamide mobilization, and in Europe they still use cyclophosphamide mobilization to a huge degree.
Right, and they are in these randomized controlled trials that we were talking about as well.
So they, truly think that they want to use for an anti-tumor effect.
Right.
Although, we've never been able to show in a study definitively that there is. Here again is the comparison between growth factors alone versus growth factors combined with plerixafor, the mobilizing agent that unvelcros the cells, as you very succinctly put it. Your ability to successfully collect patients with myeloma goes up. By day 4, 87% of patients had their 6 million CD34s collected, which is actually a very robust, good collection. Whereas if you just use GCSF alone, it would
in the gray curve.
Would be about 56%.
And I think this is one of the things we talk about related to cost, and we should consider this because although you may have a more expensive drug, for example, plerixafor, you have more days that you're subjecting a person to apheresis. And there are a lot of costs associated with that, not only monetary, but time and physical. So the more sessions you have to have of apheresis, that's a whole nother nursing staff, a whole nother time of the day for the patient, and a whole nother sort of organizational pathway that you have to do.
And the opportunity cost of being in that bed, which could be used for another patient.
Right. So you could maybe do things faster and have more patients be mobilized. So I don't think all is lost just on the cost of drug alone, and something that each center has to consider when making their decisions about the pathway for mobilization.
Mobilization, exactly. So here is one way of doing it, which is called preemptive plerixafor, where you would give it to patients based on a CD34 count. And there is a couple of different ways that people are using it because of the cost of the drug, as you mentioned. One is just in time, where you would use it only if the patient is starting to fail a collection, or preemptive when you measure the CD34 count on the day before your mobilization. Here's data for that. You see that once patients get to about 20 CD34 cells per cubic millimeter in the peripheral blood, your collectability goes up above 2 million. So it's essentially
it's a good cutoff.
It's a good cutoff.
Yeah.
And if you're less than 10, most people would add plerixafor at that point.
Because you don't want to subject the patient to additional days of GCSF, which is not going to be successful, right? So then you're losing time, and so you want to make sure that you do something, an educated guess, basically, which is what preemptive plerixafor is.
Exactly.
And with that, as you can see, you're able to actually nicely increase the yield that you're going to get of the stem cells, which I think is really important because you want to be able to do the transplant. I mean, that's why the patient came to you. So you don't want to have failed at collection.
Yes. And here again is data for that. The plerixafor improves the yield by 3 to 5 fold. So
Right,
if you're
which is
under
huge.
10, which is a huge, and it can mean the difference between 5-6 days on the machine
Right.
versus 1 or 2 days on the machine.
And it can make the difference between 1 or 2 transplants.
Exactly,
Right.
yeah. And so here is some data from Dr. Costa's study on preemptive plerixafor.
Mm-hmm.
So he actually showed very nicely that the peripheral blood CD34 count and the CD34 count in the mobilized product were exactly correlated.
Yes.
And the number of apheresis sessions could be predicted to almost 94% precision. And the proportion meeting the mobilization target was also 94%. So mobilization is becoming not a huge barrier to transplant with the availability of these drugs and our fine-tuning how we use this. And here are the consensus recommendations again from the American Society of BMT. The goals are to reduce the overall failure to less than 5%, and
which we've done.
Which we've done, and minimize the complications, which means minimize the number of sessions, and optimize resource utilization, which you very clearly pointed out. And then again, for patients with myeloma, these are the consensus recommendations. That is to limit the steady-state mobilization with GCSF to people who have just less than 1 line of therapy, one or
not multiply treated.
And if you're multiply treated, consider using plerixafor
upfront.
Earlier, upfront. Yes, exactly. So I think we've had a really good discussion about some of these major points that that underutilization of transplant, despite overwhelming evidence to the benefit, is a major challenge in the United States. And it's a challenge for our patients, it's a challenge for our referring physicians, it's a challenge for us, where we cannot get this effective therapy into the community to the people who need it the most. I want to leave the viewers with this, that early transplant referral is critical in getting patients to transplant. And then if that cannot happen, collecting stem cells and holding it for transplant at relapse. And for the patients who have undergone an early transplant, if they get a significant benefit from it, at relapse, maybe use the cells again. So there are significant advantages to having early transplant referral, and I think we should emphasize that to the referring population of physicians and also the patients with myeloma. We'll have a second segment of this activity where we'll continue our discussion with topics around induction, maintenance, and some of the changes that are happening with conditioning regimens for multiple myeloma and some cases.
Great.